name's Brian Cuthbertson. I'm Professor of Critical Care at the University of Aberdeen, and I'm also a consultant in anaesthesia and intensive care in Aberdeen Royal Infirmary. So BMP, and indeed its pro-hormone NT-proBNP, are broadly the same thing. They correlate very strongly. So although we're using these terms, both of them in different studies we've done, essentially it's the same thing. It's a compound that's produced mainly by the heart, the left ventricle in particular, in response to volume loading, and actually causes natriuresis and diuresis in response to increased left ventricular volumes. These responses are very important physiologically in terms of cardiovascular homeostasis. Importantly, BNP and NT-proBNP are known to be predictive of outcome in left ventricular failure and indeed in acute myocardial infarction, and that's what led us to the work that we've been doing in a higher risk surgery. In patients with heart failure, it is indeed a predictor. Indeed, in the general population, regardless of whether they have heart failure, it is independent predictor of mortality. So in fact, what we'd be looking for in surgical patients is additive value above and beyond that predictive level, which would mean that BNP not only just predicted it as it would in anyone in the street, but actually added increased accuracy to your predictions in these patients, both in the perioperative period and in the years after that. We initially asked the hypothesis in cardiac surgical patients, would BNP be predictive of perioperative morbidity and early postoperative mortality? Followed these patients up to look at later mortality after surgery, and then moved on to non-cardiac surgery to do exactly the same work in that group. So BNP, if you exercise, if you are treated for heart failure, for instance with an ACE inhibitor, your BNP levels will indeed reduce, and that will be a marker of an improved prognosis in response to treatment. So yeah, the BNP is modifiable. What we have not yet been able to do, and will be future work, we'll be seeing if by modifying it in the perioperative or preoperative period that we actually can work. That we presented today was just a small bit of work we did in intensive care, looking at people who come admitted with sepsis. We compared BNP in the early at time of admission versus some rather sophisticated echocardiographic parameters, such as EE', a measure of left ventricular function, which is not available in routine echocardiography, but it is probably the best measure of LV function. And in fact, BNP correlates a very high level with that EE' measurement. I think the potential usefulness of this, and again this is more out with the surgical area, this is the data I was presenting was intensive care, is that it may prevent you having to do an echo to quantify someone's LV function at the time of admission with septic shock, for instance. So a high BNP would suggest they did have LV dysfunction, a low BNP would suggest that it's not as big an element. Yeah, so in fact the half-life of BNP is short, and its responsiveness to stimuli that's what it does physiologically. So in fact, although we've not done a lot of work in response to stimuli, it does seem to change rapidly, for instance in acute myocardial infarction, acute myocardial ischemia, acute left ventricular failure, and therefore it does seem to be a rapid response. I think in the cardiac surgical situation, where we've done a study which is about to be published in 1,000 patients, it suggests that BNP will add to existing risk factors, and indeed so will EGFR. So they now need to be meshed into the existing models such as the Euroscore, and that's work that we're trying to model just now. But I think that it will have a place there because it adds extra predictive accuracy above and beyond things such as Euroscore. In the non-cardiac surgical situation, my hope is, and these two studies we're doing will hopefully show this, that rather than doing cardiopulmonary exercise testing or a dynamic measure of left ventricular function as a pre-op assessment, that in fact we'll do biomarker tests such as BNP, simple and cheap, and we'll give you a rapid answer about the risk of a patient. And as I say, this may entirely replace measures such as CPX, or it may be that it's complementary to them, and that's data that we will hopefully have in about 3 years' time after these two big studies finish.